Hey, welcome everybody to another episode of Mind Matters, Navigating Head Injuries and Concussions. I am Kiley Como. I'm sitting in for Shane Smith today here at Shane Smith Law. And we're going to be talking to you today with Dr. Mbeo with Brain, Spine, and Pain. Dr. Mbeo, is so wonderful to see you again.
Thank you. I'm happy to be here. Thanks for making the time. Thanks for having me here. I'm always passionate about opportunities to talk about the brain, passionate about opportunities to talk about traumatic brain injury. That's something that, for a long time as a neurologist, I navigated this space. As we were chatting about earlier, Kylie, my background as a neurologist took me to the neuro-intensive care unit. So the ICU, where we take care of the critically injured, neurologically ill patients, traumatic brain injury in its other manifestation. And so I found myself quite passionate about taking care of that subset of patients, the acutely injured, neurologically ill patient. As I navigated the ICU space, I came to realize, we do a lot of good things in the intensive care unit. A lot of things would be left to the patient or the family's own devices once it was time to leave the intensive care unit and certainly get back reintegrated outside. So that's what led me to setting up the Brain, Spine, and Pain Institute, a place where I can see patients that have a different degree of brain injury or brain injury after that acute injury. So passionate about those patients and helping out. And so I'm glad that we have this chance to talk through the neurologist's perspective of, we'll call it the earlier spectrum of traumatic brain injury. We'll call it mild traumatic brain injury. As you know, it's considered a misnomer when we call it mild because the consequences are by no means mild. But again, that's the subset of patients we'll be talking about. How I'd love to talk about that subset of patients is, perhaps even in a series if we're going to do that. Where we'll talk about today, for example, just the basics of that initial evaluation of that injured patient, the brain injured patient, and then in our subsequent discussions, where does that evaluation take us in terms of deeper dive into diagnostics, in terms of deeper dive into therapies, and in fact even cutting edge therapies. But for today, we'll talk about how does that neurologist evaluate the acutely mild traumatic brain injured patient, the concussed patient. Now, if we think through definitions, how do we define a concussion? What's that? How do we recognize a concussion and how do we define it? So concussion, as I talk to my patients, what I try to help them understand is that a concussion is more than that singular event. So it's more than that one event that transmission of force to the brain is what we'll call it. So by whichever mechanism, it could be direct transmission of force to the brain. It could be transmission in the form of acceleration, deceleration forces being transmitted to the brain. So that's just part of it though. So there's that transmission of force. Now, when we think through concussion, after the transmission of force, there's the neurologic dysfunction that results from that transmission of force to the brain. So that's how I look at concussion. So the transmission of forces to the brain, be it directly impacting the brain, we see that in contact sports or say in auto injury, maybe head against the steering wheel or against the window. So that direct, and that's easy to visualize. A little more challenging to visualize as a mechanism is acceleration, deceleration. In fact, we in the past didn't used to recognize that part, that acceleration, deceleration, but truly that on its own can cause, concussion level forces and then the consequences of the concussion. So in that initial, so as I try to talk to my patients to talk to them to try and understand, what happened, my goal is to try and identify that clear proximate cause for these feelings that we're relating to a concussion. Well, what's that clear proximate cause? Was there that force? But is there a mechanism that we can think through that could have caused that? But not only that, the next part is, what did you feel after? Or what are those, or immediately, and then thereafter, what did you feel? And so many patients will have a host of vague complaints, and many times, concussion in that setting is missed because we are so focused on the other musculoskeletal things that result in the force. We're focused on the neck, we're focused on the low back, we're focused on the knee, the shoulder. As we ask probing questions, we realize, what was your thinking right after? Or what did people say? My thinking was not clear. I didn't know what had happened and I was dazed, confused. It was all a blur. When did things start making sense? Perhaps when I got to the hospital, the people were talking to me and I did not know what was being said to me. Things of that nature, that gap in awareness, dizziness immediately after the impact. I tried to step out of the car and I felt intensely dizzy. I had this intense nausea and, my ears were ringing. Everything was blurry. So it's, a lot of, physical, vestibular, cognitive associations. Headache. So as soon as it happened, this intense headache that I haven't felt before, and since then I've been dealing with this headache that I have headaches every now and then, but this headache, this is different. So it's a lot of those mood changes. Again, my wife says I've become really grumpy, or my husband says it's really hard to spend time with me nowadays because I'm really irritable. My kids say, but Dad, stay away, or Mom, stay away. Those mood changes we don't think about. Sleep. And many times when I ask my patients, I say, how's your sleep? And they say, what sleep? And so, so sleep gets impacted. In fact, I really associate those sleep changes with having had a concussion. Many people, if you just ask that one question about sleep, that's usually one it's almost uniform, some form of sleep change. And, fine, it could be related to musculoskeletal aches and pains. But again, sleep on its own can be significantly disrupted. So there's that history of an event or a mechanism that could cause concussion level injuries, and then beyond that, the neurologic presentation. Those complaints that many patients will come in with thereafter. So I usually try to I define concussion as that the forces alongside the deficits in brain functioning or neurologic functioning that matches up. So that's how I define it, and many people look at it that way. Now, many times as we navigate that early continuum, so many of these patients will, they'll wind up in the emergency room with vague neurologic complaints. They'll have, that entry-level neurologic exam or that entry-level evaluation. They'll have entry-level imaging, which will be a CAT scan, and they'll say, Doc, I was told that I did not have a concussion, and I'll ask why. Well, because my CAT scan was negative. And so I try to help them understand. I say, well, a negative CAT scan does not rule out a concussion. And I try to help, some of our medical colleagues who might not have that same depth of understanding. I mean, a CAT scan in that setting has a role. We're trying to rule out a bleed in the brain. Is there a bleed in the brain? Is there anything significant in the brain that you will see on that CAT scan? That's all it is. It's a screening scan. Doesn't take away from the diagnosis if it's negative. In fact, most of the time it is negative, and that's okay. And so negative CAT scan, good, doesn't rule out the concussion. It's again that history of the event and then the symptoms thereafter. And then once done with that initial evaluation, many patients get told, well, hey, head on out and maybe follow up with your primary doctor, or follow up with a sports medicine doctor, or maybe follow up with a neurologist. And so as we go through that continuum, the time that many of these patients will see me as a neurologist will be at that point in time, at least in my outpatient life when I'm not in the neurocritical care unit. Outpatient life, that's where they'll see me when the event has happened. Some of the consequences are being felt from that event, and then here we are, a week, days, weeks, even months, even years actually later. So we'll meet on the outpatient side. As I go through, again, just taking that history, trying to, in my mind, really clarify: could there have been forces that could have caused this, significant enough to cause this concussive injury, the acceleration, deceleration, actual trauma to the head? Could there have been that neurologic presentation that matches up with a concussion, cognitive status after, and all the things we just talked about? At that point, I usually start to think through, are there any objective tests that we could use to, again, just put a little more weight on understanding this concussion. So objective tests, and I'll tell you this, in terms of concussion, at the present time, there's no gold standard test. There's no one test. So there's no gold standard test. It still remains a clinical diagnosis. In 2024, it remains a clinical diagnosis. Again, history of what happened and the neurologic consequences thereafter, and the neurologic exam. And so, as we think through objective tests, in my mind, the objective tests are aimed at perhaps putting a little more weight on this suspicion of a concussion. And I'll talk through the testing. Putting weight on that, it, for me, also helps think through what can we do to help out. So is it not? And then what can we do to help out based on what the objective tests will show? Now, when I think through objective tests, what objective data can we gather? Perhaps the one I am most excited about in 2024, and it's still in its infancy, this particular test, and I know as the years go by, this is going to it'll take a front seat in concussion diagnostics. It's biomarkers. So serum biomarkers. Quite exciting to me, and it's one that I actually I rely on heavy, especially in that acutely injured, acutely concussed individual. But I'll tell you this: in the biomarker clinical trials, in the studies that were looking at biomarkers, even up to a decade in, there were people that had prolonged post-concussion symptoms and had elevated biomarkers. So even, so for me, using that same rationale, seeing a patient weeks after, seeing them months after, seeing them even years after, we've seen it elevated even years after to speak to the utility of the biomarker test. So I put a lot of weight on it, and I know that we've got a long way to go before it becomes standard. But the biomarkers, and which ones are those? There's perhaps two that have been looked at the most, and for now are the most available. A certain protein in the blood, it's called GFAP. Mm-hmm. And usually a marker for neuronal injury, and the other marker is UCHL1 and GFAP. So those two markers. And as I try to help my patients understand what we're doing, doc, I came with these neurologic symptoms. Why are you recommending this blood test? As I try to explain it to them, I say, well, if you went to the emergency room right now with chest discomfort, if you had chest pain and you went to the emergency room, there's probably about three things that they would do, a few other things, but diagnostically, they put an EKG to look at electrophysiologic biomarkers, so cardiac biomarkers, like your EKG, are there changes on the heart monitor? The other one would be a blood test, that's serum test, looking at troponin and CPK, but again, looking at troponin to see in the blood, can we detect a protein that tells us that the heart has been injured? Biomarkers are taking us the same place in concussion management. So where that brain injured individual, we are able to detect in the serum elevations in GFAP and UCHL1. And how I help my patients understand it, a negative troponin, if I checked it in a few weeks, for example, and it was negative, that does not say that you did not suffer a myocardial infarction. And then I look at UCHL1 and GFAP the same way. A negative a few weeks later doesn't say you did not have that event, just tells me your body has cleared it. But certainly a positive one, a positive level of either one is quite telling. So I've had patients where months, years after, we have elevations in those markers, and they have persistent post-concussion symptoms. So quite interesting, that association. So the biomarkers, that's one of the things that I usually I put some weight on, and I know we've got ways to go before it's standard available everywhere, but quite exciting to me. The other direction I take as we again put together information on what's happened neurologically is vestibular testing. So balance testing, and at the very, very basic, at least my approach to it is a test called the computerized test of sensory imbalance. So the CAT-SIB, or the modified CAT-SIB. So a test that helps quantify balance dysfunction in a few scenarios. So eyes open, eyes closed, varying surfaces that the patient is challenged through. And I'll tell you, that also is quite telling as far as, being able to pick up on post-traumatic brain injury or post-concussion vestibular and balance dysfunction. Quite telling. I can't tell you, it's almost every day when I'm talking to my patients that have concussion or come in with concussion symptoms, and perhaps we're focused on the headache. And then I ask, well, how's your balance? Well, my balance is great. And, it's time for that part of the test. Let's do the balance test. And the very first at the bedside, what we do is what's called a Romberg. So stand at the bedside, put your feet together, arms out, and close your eyes. And wobbly. And I say, did you feel that? Yes, I did. I didn't realize that. Interesting. Okay, let's step on a force plate. So a force plate quantifies the sway. How much sway do they have in all directions for a few seconds as we do it in all those scenarios? And my goodness, many times these are young athletes who they are at the prime of their athletic abilities, and they get surprised after this concussion how impacted their balance function is. But I tell them, this is not something to be alarmed about. It tells us where do we go from here. If we detect profound sensory or profound balance dysfunction after the concussion, it tells us that perhaps one of the things we need to start focusing on is going to be balance focused rehabilitation. So it tells us where to go. So it's very actionable. So the balance testing is in my opinion, is key in that initial evaluation. And there's other ways we assess balance without complicated equipment. The force plate is complicated, but at the bedside, there's other ways we can assess balance. But a balance evaluation for me is part of that toolbox. The other part of the toolbox, and I usually match this up with many symptoms. Talk about these headaches that many concussed individuals will have. This persistent headache, this bright light sensitivity, the photophobia that many will experience, the double vision, the trouble reading, and notice that all these are tasks that are reliant on what the eyes are feeding to the brain. So it's the eyes perceiving, but then the eyes are perceiving and feeding that information to the brain. And then many times that whole circuit and connections to that circuit can be disrupted. So really important to have a vestibular ocular test. So a test that helps us look at eye movements and the subtleties that those disruptions can bring. What do I mean? As a neurologist at the bedside assessment is follow my finger just with your eyes. Yeah. And so we track and really easy to miss those things. Unless there's overt jumpy movements, the nystagmus, the overt, jumpy movements, or, nystagmus. So unless that's present, many times these subtleties are quite easy to miss. Now, when you use certain tools that help magnify those eye movements and help really target, so saccades, so again, just the smoothness of movement, say in the circular plane, and the smoothness of movements, because our brain is used to receiving this information in that most refined manner. Really pure circular movement, really pure vertical and horizontal movements, and quite telling when you use certain tools, certain eye movement assessment tools in that concussed individual. Quite often, here we will identify, what seemed pretty smooth on gross testing. You'll identify, my goodness, and I'd love to show that to you in subsequent discussions. I'm going to show that to you. But some of those profound eye movement abnormalities that at the bedside seem normal, but when you actually do sensitive testing, you will detect that in many of these concussed individuals with a correlate to some of the cognitive fatigue, because you're really having to think many times before saying or determining what is this I'm reading, or you're really having to focus really hard before being able to see what is this object right in front of me, or things of that nature, or correlates with the headache and the cognitive symptoms and things, and the balance dysfunction. So that balance and the visual assessment using certain tools, quite key. When I say certain tools, there's many. I think there's different devices that have their pros and cons, and many of them similar to what's called a video nystagmogram. So VNG is probably the grandfather of all these, and it's truly the tool that I'll bring out when these other tools need they need that again, the backing of the grandfather of all these tests. VNG, but quite important in that early concussion assessment to tell us, because not only does it help cement that thought process that this indeed is a concussion, but if we identify those dysfunctions, part of the rehabilitation protocol is let's do some visual and vestibular rehabilitation to try help with your symptom. And then it also helps validate. You're not imagining all this. You're not imagining that things seem a lot jumpier than usual, or you're not imagining that when you're seated in traffic nowadays, when you see vehicles moving on the side, you all of a sudden, the world just seems completely thrown off. So visual and vestibular testing, I feel, are also, quite important in that early evaluation.
Well, that does it for another episode of Mind Matters, Navigating Head Injuries and Concussions. Thank you so much to Dr. Mbeo for speaking with us today. We got to hear a lot about kind of what a concussion is. I think that's kind of a nebulous term, so it was very helpful to maybe get a better understanding on just what a concussion is for a lot of our listeners out there. Please come back next week where we're going to kind of dig more into how do you diagnose a concussion, and how, clinicians like Dr. Mbeo do that in clinic, and then talk more about some of the treatment strategies for those concussion injuries. As always, please remember to hit like and subscribe for more episodes of Mind Matters, and then, of course, hit that bell for all the notifications on our latest and greatest content. And remember, if you're in pain, call Shane at 980-999-9999.
In pain, so I call Shane. 980-999-9999. In pain, call Shane.